Öncelikle gelen arkadaşlara teşekkür ediyorum.
Thank you very much. Thank you very much. After two speakers' great speech, I'll try to make another great speech, but it will be shorter than their speeches. When we talk about neurobiology of sleep in autism spectrum disorders, we are actually talking about very similar mechanisms. We need to be more careful about this disorders, clinical reflections, and sleep-related issues, reflections on our clinical practice. We know that ASD can be defined as a disease that corresponding to the atypic behavioral phenotype revealed by heterogeneous etiology and cerebral dysfunction. 8 autism cases were included, and wakefulness, EEG, MRI, web AVR, karyotype analysis, monoamines, catecholamines, everything was studied, and approximately 88% of the cases they found some pathologies. So from this onwards, we can understand we work with multifactorial diseases. So inside that disease, multifactorial issues are intermingled. That's why the etiology of that disease cannot be elaborated. In the autism spectrum disorder, sleep disorders are more common. But from which mechanism that problem takes its root, we don't know it yet. And we have to work more and more. In the autism spectrum disorder, we see some different types of sleep disorders and neuroanatomic structures, fMRI studies, and other studies, I believe, will be very much illuminating for our roadmap for the future studies. In autism, 44% and 83% is the range of the comorbidity prevalence. And on the developmental retardation, we see 40% normal development, 32% sleep disorders accompanied to ASD. Insomnia accompanies to autism spectrum disorders the most among all other sleep disorders. In autism, we see sleep disorders very frequently because there are certain neuroanatomical, neurochemical changes, and the regulation of sleep is distorted, but there are some concomitant psychiatric comorbidities such as anxiety, depression. So when the rituals and other behaviors may arouse during sleeping phase, and they can create some disturbances and restless leg syndrome, other sensory related problems can create more sleep disorders for ASD diagnosed individuals, or GI tract problems, reflux, or some other metabolic disorders can create more problems for the ASD, and also side effects of the used drugs can create bigger impact on ASD individuals. One-to-one history taking from the patients when you work with ASD individuals is not easy. You need to talk to the parents of the individual, or maybe you can examine the person, putting him or her into a clinic or a sleep center. Daily practices, behavioral problems and functions of the person may be worsened, and brain maturation, increasing stress in the family. This must be evaluated. You know it, I'm sure you have realized that increasing the stress in the family creates big problems such as divorce or some other stress causes may create sleep disorders for ASD individuals. What does sleep do? What is the benefit of sleep? if we continue from the previous speaker's speech, we know that body is renewed when we sleep. Regulation of the metabolism takes place, and protection of energy takes place. Neuronal plasticity and realization of network integration is supported. Intellectual performance is protected. For these purposes, sleep is indispensable. These have been mentioned before, and that's why I will cut it short. Circadian rhythm of the sleep has not been stated by the previous speakers. I'll try to elaborate on it, because majority of the sleep and autism related studies are related to melatonin, but circadian rhythm of sleep becomes more important for us in ASD individuals. Process C is important from that aspect. Process C helps us to sleep. So it is a homeostatic impulse for sleep, and need of sleep increases during the day, and before we sleep it has peak. And process C maintains wakefulness, and it regulates circadian rhythm, and during the night time process C decreases a bit more, and after that the gap between process S and C difference is closed. When process C outperforms process C, we wake up. Unless there is process C, we can sleep with process S, but there won't be any regulation, organization, and order of our sleep. So they try to balance each other. I'll try to elaborate on it with the scheme. You can see melatonin increases, and when it has its peak level, process C comes to the bottom level, and then we fall asleep. When this gap is closed, when we have the lowest body temperature, we start to wake up. This is how we sleep and wake up. And neurobiology of sleep was taught by the previous speakers. Neural system that regulates the sleep and wakefulness. We know that ascendant reticulate activating system is very important, and tuberomammillary nucleus and orexin neurons and ventrolateral preoptic area and ventral tegmental area are the most important areas that regulate our sleep. And also there are certain neurotransmitters such as histamine, orexin, serotonin, dopamine. I'm not dwelling on these neurotransmitters one by one, because I don't believe that it will be too comprehensive if I mention everything one by one. GABA, glutamate, and serotonin are repeatedly mentioned when it comes to sleep-related disorders in the ASD individuals. When serotonin is low, GABA activity is low as well, and dopamine is low. So these are affecting sleep, and they can create problems before we fall into sleep. And these are reticular activating systems, brain stem nuclei, and neuroadrenergic projections, and serotonergic projections, dopaminergic projections, and histaminergic projections. These are effective on the sleep and wakefulness. We mainly work with infants and children, and we need to look at their rhythms as well. Babies, infants, and children, a neonatal, 7 or 8 hours. Daytime sleep is sufficient. Daytime sleep is more, and nighttime sleep for neonatals is less. Totally, as time goes by, sleep decreases, but daytime sleep, approximately at the age of 3, is eliminated. So after the age of 3, infant does not need to sleep during the day, and nighttime sleep becomes more sufficient. Neonatal period and infancy, then other periods as the age advances, we know that daytime sleep is eliminated. Newborns, here you can see how much they sleep, and brain maturation from the REM and NREM can be understood better. But when we look at this chart, actually this is not very interesting. These are the things that we already know. When we look at autism spectrum disorder, neurobiology of sleep associated with ASD, these are some of the details of the systems that I mentioned. GABA and melatonin plays a critical role in falling into sleep. It is important for process S and process C cycle, and these two molecules are very influenced on ASD. In terms of the balance disorder between GABA and glutamate, we know that in the ASD that balance disorder increases. GABAergic interneurons are distorted, and with respect to GABA, in the 15q arm, we know that gene is related to autism, so there is an area that is allegedly related to ASD. The expression of these autism-sensitive genes could create an impact on the sleep. How does it occur? The brainstem areas create a neuronal net that regulates wakefulness, including pedunculopontine, laterodorsal tegmental nuclei, locus coeruleus, and dorsal raphe. Neurons that make projection from the preoptic area of hypothalamus trigger the sleeping by inhibiting the brainstem areas. Melatonin synthesizing area is on the pineal gland. It is located on the medial part of the brain. Towards the end of my presentation, I'd like to talk about some parts of tuberomammillary nucleus. Why is it important? Because I'm sure that you see it very frequently, such as atarax usage or antihistaminergic agents usage. Many children who cannot fall into sleep are trying to be treated with these antihistaminergic drugs. When children are having some problems in falling into sleep, many physicians or pediatrists may prescribe these drugs, but they are not permanent in providing the effect. Tuberomammillary nucleus is the base of the posterior hypothalamus, and it is the only source of histamine in the brain. Histamine release at higher level in wakefulness decreases at NREM, and it increases sleep at these two systems, no matter what it is. Antipsychotics that we use provides antihistaminic effect. Circadian system helps sleep and wakefulness cycle. Melatonin increases. At the end, we can fall into sleep. Melatonin activity on insomnia treatment on autism is shown with several studies. In addition, abnormalities in the malignant melatonin or urine metabolites have been demonstrated in individuals with ASD. Nocturnal melatonin metabolites decrease during this sleep. There are many studies showing that truth. This is a cluster of many studies. Many studies have been compiled at this research, and that research says that melatonin in autism spectrum disorder can be related to serotonin changes as well. Low nocturnal melatonin release can have positive impact on the verbal communication. I think this is very important because it makes us think about melatonin usage in autism. To what extent we can use melatonin, whether there is sleep disorder or not. If it can heal core symptoms of autism, to what extent we can be sure of its effects and to what extent we can use it. I think it can be good for our patients. In our patients, at least I can say I have achieved very good results. And I have asked that question to my other colleagues, and many of them have given very positive feedback. Last but not least, one of our holy books, which has been published by our association, melatonin, has been said to be important in the regulation of sleep disorders of ASD individuals, whether there is disorder or not. Melatonin can enhance verbal communication skills for autism diagnosed individuals, but it has to be supported. Melatonin synthesized gene in the autistic individuals, melatonin releasing enzymes. There are certain defects, we know it. It has been detected and found by some authors. And there's something else which has been emphasized here. Rhythm has been mentioned. Yes, of course, it is very important because we can provide better organized life to individuals. Many years ago in Aleppo, very old, in the medieval times, a therapy method was found, and it refers to that found with water and sounds in a more rhythmic way. Patients were treated, healed. However, usage of melatonin in terms of providing a better sleep order, autism symptoms can be healed. Only with this sleep regulation we can have positive contribution on the autism-related symptoms. Kwarma had a study. It is related to mind concept. It says that medial prefrontal cortex and other brain areas roles are stated. Gray matter on the autistic individuals is more intense on the frontal cortex. Medial prefrontal cortex intensity increases. In spite of that fact, in the autism, we know there is a decreased relation between vertebral and lateral cortex. When the oxytocin is given in a nasal way, ASD symptoms have decreased and medial cortex functions have been enhanced. Stimulation of medial cortex changes the serotonin activity, and amygdala is effective on the price and punishment functions. It gives such a projections like this. Emotion regulation is affected by amygdala as well. Park and friends worked on amygdala, and they said that if you work on amygdala with respect to ASD symptoms, that will be more appropriate, and some changes in amygdala have been found to be crucial in autism. Orexin neurons and amygdala, you know, they are interrelated with each other. Similarly, on the amygdala, there are oxynergic neurons, and they take inputs and give output. So this is how they work together. And orexin has great impact on wakefulness and sleep. This is my last slide. I will conclude. Miray has already mentioned these facts, so I'd like to conclude my speech. There are two mechanisms: increased orexinergic system activity, decreased serotonergic system activity. Maybe as a cause or a result, there's a decrease on the REM activity. In the autism spectrum disorder, some neuromechanisms are affected. Parasomnias must be evaluated. Not only insomnia is important. When we talk about parasomnia, we know that when people try to fall into sleep, they suffer from some undesired problems, such as when a child tries to fall into sleep, he suffers from some problems, seeing nightmares, feeling uncomfortable, abnormalities on the sleeping, such as night terror or conventional waking, act out their dreams, or rhythmical movement disorder, handbang can be given as an example. The other sleep problems in ASD: obstructive sleep apnea, restless leg syndrome, periodical leg movement disorder, circadian rhythm sleep disorder, emotional dysregulation. Autistic people have difficulties in calming themselves down, sensory sensitivity. Asthma treatment increases sleep disorders. We need to remember this. Thank you very much for your patience.